Welcome to Chapter 40 of NUR 203, Respiratory Dysfunction. These are your objectives. You are welcome to read them and follow along. Check them off, whatever you like, but I'm not going to read them to you. Respiratory infections, upper respiratory infections. Oronasopharynx, the pharynx, the larynx, and the upper trachea would encompass the areas that are affected by upper respiratory tract infections. The respiratory tract is subject to a wide variety of infective organisms. Most infections are caused by viruses, like the RSV virus, which is sometimes referred to as bronchiolitis. Then there is the rhinovirus, non-polio enteroviruses, adenoviruses, parainfluenza virus, influenza virus, and the human metapneumovirus. And the ever-popular coronavirus is also sometimes affects people as an upper respiratory virus. Lower respiratory tract is your lower trachea, bronchi, bronchioles, and alveoli. Other agents involved in primary and secondary invasion include group A beta hemolytic strep, or GABHS, Staphylococci, H. flu, pertussis, Chlamydia trachomatis, mycoplasma organisms, and pneumococci. General aspects of respiratory infections. Full-term infants and those younger than 3 months are said to be less likely to get infections because of the protection from the mom's antibodies. The infection rate increases from 3 to 6 months of age. The amount of lymphoid tissue increases as a child grows, and repeated exposure to certain bugs help to build their immunity. Anatomic differences can cause children some problems. The relatively short and open eustachian tubes in infants and young children allows pathogens easy access to the middle ear. Frequent otitis media or ear infections can be a problem in the young child. Having a good immune system is normal for a healthy child, but those born with issues like BPD, CF, asthma, and allergies will suffer with these infections more often than most. RSV is seasonal, like the flu. Cold weather is not easy on children or on their parents. Clinical manifestations vary with age. Generalized signs and symptoms and local manifestations differ in young children. Infants and young children, especially those between 6 months and 3 years of age, react more severely to acute respiratory tract infections than older children do. See box 40.1 on 1128. So warm or cool mist humidifiers or mist tents can help us, as well as steam vaporizers in the home under parental control, because these things get very hot and that steam can burn, especially a child. Limit activity for children with fever, but allow limited play when the fever goes down. Older children handle the runny nose better than the young ones do. A bulb syringe can be the parent's best friend, but the child or infant's worst nightmare. Bottles of normal saline drops can become easily contaminated if you are not careful, and nasal sprays can have a rebound effect. See the nursing alert on page 1129. Fever is usually brought down by acetaminophen or ibuprofen, and often the practitioner will recommend the alternating of the two meds to cover the fever around the clock. Careful calculation must be done with both of these medications. Keep something for the child to drink around them all the time, and offer popsicles, crushed ice, and their favorite beverage so they stay hydrated. Sports drinks are not recommended for oral hydration in small children. Toddlers may actually drink small amounts better from a medicine cup or a teacup, like in a tea set, for pretend play. Any way you can get the fluid in them is a good way. Let them suck it out of a syringe. I don't care. You need to get them hydrated. Loss of appetite is common with acute infections. Forcing them to eat may cause nausea and vomiting, which will compound things. Feeding the sick child is covered in Chapter 39. Support the parents while caring for their sick child because they are not feeling well. They will be irritable and only want their mama. Remind the parents not to give any meds that were not prescribed for their child. Leftover amoxicillin from the sister's illness 2 months ago is a big no-no. Acute viral nasopharyngitis, see box 40.3 on page 1131. This is considered to be the common cold, and all we can do is treat the symptoms and try to make the child as comfortable as possible. Acute pharyngitis. The most important thing to remember about GABHS, strep infection, is that it can cause rheumatic fever, an inflammatory disease of the heart valves, joints, and central nervous system. We will talk more about this in Chapter 42. The clinical manifestations include pharyngitis, headache, fever, and abdominal pain. Don't forget the abdominal pain. Strep should be suspected in children older than 2 years of age who have pharyngitis without exudate and nasal symptoms. The tongue may appear edematous and red. They call that a strawberry tongue. And the child may have a fine sandpaper rash on the trunk, axilla, elbows, and groin, seen in scarlet fever, which is also a strain of a group A strep. Diagnostic evaluation shows that 80 to 90% of pharyngitis is viral, but a rapid throat culture should be done anyway to rule out group B strep. Care includes warm saltwater gargles for throat discomfort, hot or cold compresses to the throat, liquid medications and not tablets, cool liquids for hydration, and keep them away from others for at least 24 hours of antibiotic therapy. This is what the throat may look like with tonsillitis and pharyngitis. Tonsillitis. The tonsils are masses of lymphoid tissue encircling the nasal and oral pharynx. The tonsils are much larger in children. The palatine tonsils are the ones usually removed in a tonsillectomy, along with maybe the adenoids and the pharyngeal tonsils. Tonsillitis is a common cause of illness in young children, and it can be caused by viral or bacterial infections. Tonsillitis is self-limiting, and most are caused by a virus. Repeated bacterial infections, though, like strep, may require that the tonsils be removed. After a tonsillectomy, remember that a sign of bleeding in the recovering child is frequent swallowing. Ice collars and cool things like ice cream and ice pops or crushed ice is helpful. Zofran may be given for nausea because vomiting is not good when you just had your tonsils removed. And the blood that trickles down your throat after surgery like this irritates the stomach, so it may very well cause nausea. This is a picture in your book that shows the tonsils and the different types of tonsils and the tonsillar masses where they're located. Influenza, commonly known as the flu, is caused by 3 orthomyxoviruses, which are antigenetically distinct, type A, B, and type C, which is an antigenetically stable and causes milder disease. Clinical manifestations can be mild, moderate to severe. Dry throat and nasal mucosa, dry cough and hoarseness, flushed face, photophobia, lack of energy, and subglottal croup in some infants. Therapeutic management includes Tamiflu and several other antiviral drugs that should be started at the first signs of illness. Prevention includes the flu vaccine or inhaled vaccine and staying away from sick people. Symptom management and antipyretics, except no aspirin. Otitis media is the presence of fluid in the middle ear along with acute signs of illness. Most OM occurs within the first 24 hours of life. Children living in a household where a smoker lives are more likely to have otitis media more often. Preschool boys are affected more than girls. Diagnosis is made using an otoscope to examine the tympanic membrane. If they see OM, it will be a bulging yellow or red eardrum, and there will be pain in the ear. See boxes 40.5 and 40.6 on page 1136 for more about otitis media. Amoxicillin is the treatment of choice in the initial episodes. 10 days for severe cases and 5 to 7 days for not so severe. The myringotomy or incision to drain the ear is sometimes done, or a tympanostomy. Tube placement and adenoidectomy may have to be done. Immunization for pneumococcal conjugate has reduced the incidence of acute otitis media in many infants and children. Infectious mononucleosis, the incubation period after exposure is approximately 30 to 50 days, but the onset of symptoms may appear anywhere from 10 days to 6 weeks. See box 40.7 on page 1138. The etiology and pathophysiology, this is a herpes-like Epstein-Barr virus, and they do the monospot test, and therapeutic management. It's self-limiting, usually gone in 7 to 10 days. Care management, do not expose others and treat the symptoms and provide comfort care. Croup syndromes, characterized by hoarseness, barking cough, inspiratory stridor, and varying degrees of respiratory distress. Croup syndromes affect the larynx, trachea, and bronchi. And we'll talk about all these other things here listed in just a second. See table 40.1 on page 1139. Acute epiglottitis is a medical emergency. Clinical manifestations: sore throat, pain, the tripod position. If you don't know what that is, look up a picture of what the tripod position is. Drooling, difficulty swallowing, inspiratory stridor, mild hypoxia, and distress. Therapeutic management: prevent progressive respiratory obstruction. Throat inspection only by professionals. Intubation or tracheostomy may be necessary. Care management: allow the child to remain in position of comfort and do not panic. Get them help as soon as possible. Acute laryngotracheobronchitis, or LTB, is the most common of the croup syndromes. Generally affects children under the age of 5, like 6 months to 3 years of age. Organisms responsible is the RSV virus, parainfluenza, mycoplasma pneumonia, influenza A and B, pneumococcal infections, and staphylococcal infections. Remember that LTB can usually be treated at home as long as the parents are taught what to look for if the child worsens. Stridor that cannot be relieved or any respiratory distress should be, addressed immediately to the ER. So the manifestations of LTB usually preceded by an upper respiratory tract infection, inspiratory stridor, suprasternal retractions, and a barking or seal-like cough, increasing respiratory distress and hypoxia, and it can progress to respiratory acidosis and respiratory failure and death. Read the nursing alert boxes, both of them, on page 1141. Therapeutic management: maintaining the airway, maintain hydration orally if possible, or IV if they have to be admitted to a hospital. Nebulized mist with supplemental O2. Nebulizer treatments like epinephrine, steroids, Cool mist vaporizer, or just a ride in the car with the windows down on a cool night, or if it's cool, just take them outside into the night air. They do recommend this as a treatment. Care management is continuous, vigilant observation. Acute spasmodic laryngitis, also known as spasmodic croup. This occurs mostly at night, and then the child feels fine the next day. May be caused by allergies, inflammation mild or absent, most often affects children 1 to 3 years of age. Therapeutic management similar to that of infectious croup. Bacterial tracheitis, infection of the mucosa of the upper trachea. Distinct entity with features of croup and epiglottitis. Clinical manifestations similar to that of LTB, may be complication of LTB, and there's thick, purulent secretions that result in respiratory distress. Therapeutic management and care management. Vigorous management is required. Humidified oxygen, antipyretics, antibiotics, and possible need for intubation or mechanical ventilation. Infections of the lower airways is considered the reactive portion, so you may have heard of children with reactive airway disease. See the table 40.2 on page 1141 for more information about the differences here. Bronchitis, also known as tracheobronchitis, is mild self-limiting disease. Causative agents, usually viral. Clinical manifestations, you have a terrible cough that just doesn't seem to want to quit, and it's mostly upper airway. Cough suppressants, fluids, and rest are recommended. RSV, also known as, especially in HESI world, bronchiolitis. Box 40.8 on page 1142 tells you about the signs and symptoms of RSV. Remember that CPT is chest physiotherapy, and if you don't know what that is, you might want to look that up, because you're going to hear that a lot in pediatrics. Synagis is a drug that's used as a preventative. You may hear it referred to as a vaccine. That's Synagis, Synagis, is not a vaccine. It's given IM to infants, usually, or children who are compromised somehow, very high risk, like preemie babies, or babies that have heart and lung issues. RSV season is winter through early spring, and these babies will get this expensive IM injection once a month during RSV season. Ribavirin, you may also hear of, used to be the treatment of choice for RSV babies, but the American Academy of Pediatrics has stopped using this. Unless the child is going to die, if they don't use it to save their life, is the only reason they'll use it. They must have a negative pressure room to put the child in, and they will be on strict isolation. The nurse will only be able to be spelled to come out for bathroom breaks. It's a horrible time when you're isolated in a ribavirin room. Been there, done that. Pneumonias. Pneumonias is an inflammation of the pulmonary parenchyma. Is common in childhood but occurs more frequently in early childhood. Pneumonia can be viral, bacterial, mycoplasmal, or aspiration of a foreign substance or a foreign body can cause pneumonia. See page 1143 for the age groups and types of pneumonia associated with them. Lobar pneumonia affects different lobes in the lungs. Pneumonitis is a localized acute inflammation of the lung without toxemia associated with lobar pneumonia. And supportive and symptomatic care is needed for all of these. Viral pneumonia occurs more frequently than bacterial and is seen in all age children, mostly associated with RSV in infants and influenza in older children. Atypical pneumonia refers to pneumonia that's caused by pathogens other than the traditionally most common readily cured bacteria. With bacterial pneumonia, the child may have acute otitis media and pleural effusion as complications of the pneumococcal pneumonia. This is a child sitting semi-erect for comfort in respiratory distress. He has the oxygen mask on. Pertussis or whooping cough, caused by Bordetella pertussis. In the United States, occurs most often in children who have not been immunized. There is a vaccine for this. You can cough so hard with this infection that you can get conjunctival hemorrhages, syncope, rib fractures, have insomnia, and weight loss. In younger children, they can have pneumonia and seizures. Refer to page 923 for more information about this disease. It was completely eradicated in this country a few years back, and now it's back because people don't believe in getting vaccinated, or we have a lot of illegal immigrants who don't know they can get vaccinated for free, but they won't go to the clinic because then they might call ICE on them, so it's just a mess. Tuberculosis, caused by the Mycobacterium tuberculosis, human and bovine varieties. Transmission modes, urban, low-income, non-white populations. Usually these populations of people live with multi-family members under one roof, and one member gets it and they pass it on to the rest of the family. Diagnostic evaluation is done usually at the health department and followed very closely through their treatments by the health department. Treatment includes a course of medications such as INH, PZA, and rifampin for at least 6 months. And remember that the INH is considered a low-level chemotherapy drug. Diagnostic evaluation, like I said, is made through symptoms. Prognosis is good if they're treated and they stick with the treatment regimen. So testing is recommended. Procedure: the Mantoux test, purified protein derivative used, standard dose and administration technique. Visit the Florida Health Department website, which is listed here, for more information about TB and how they test it and treat it. This is a list of some of the drugs and the regimen. Compliance is absolutely essential. Can't be stressed enough with these patients. Foreign body aspiration. The things you see listed here on this slide is a very short list of the things that can be swallowed or aspirated by a child. If you can see it and touch it and put it in your mouth, a lot of them will do just that. And if they can't swallow it, it gets stuck in their airway, then we have a problem. You can try back blows and chest thrust to help the child that's having trouble breathing to dislodge whatever it is, but you never, ever do a blind sweep in the child's mouth because you may cause it to get lodged into the soft tissues or into the folds of the trachea, which is going to make it even harder to get out. Prevention: keep your house baby-proofed, watch your children, crawl around on the floor and see what they might see as a toddler and pick up and put in their mouth. Care management: you need to get help immediately in this case. Doing CPR is probably not going to help because if the airway is blocked, you're not going to be able to get any air in. So you have a serious, serious problem. Aspiration pneumonia, risk for the child with feeding difficulties. The severity of the pneumonia depends on the pH of whatever materials they might have aspirated. So feeding techniques is important. If you have a greedy baby who wants to gulp their feedings and they get too much milk in their mouth because the hole in the nipple is too big, you may need to go to a smaller sized nipple to keep them from getting too much milk, or you can pace them by sitting them up and taking the bottle in and out of the mouth every few sucks. There are ways to prevent that, but you have to watch these babies for aspiration. We no longer use talcum powder or baby powders to sprinkle all over the baby like we used to do when I was a child, because the little particulates get inhaled into the baby's lungs. So if you want to use powder, you put it on your hand away from the baby, rub it on your hand, and then rub it on the baby. That's the way around that. Pulmonary edema is movement of fluid into the alveoli and interstitium of the lungs, caused by extravasation of fluid from the pulmonary vasculature. Cardiogenic is caused by an increased pulmonary capillary pressure because of an increase in pulmonary venous pressure. This can be too much IV fluids, left ventricular heart failure, heart rate disorders, severe hypertension, or severe renal disease. Non-cardiogenic pulmonary edema is caused by various conditions that result in increased pulmonary capillary permeability. See page 1149. Acute respiratory distress syndrome is not just in adults. This is not adult respiratory distress syndrome. It is acute respiratory distress syndrome. It's potentially life-threatening, inflammatory lung condition that may occur in both children and adults. This may be caused by direct injury to the lungs or a systemic insult that leads to an indirect injury to the lungs with subsequent hypoxemia and respiratory failure due to non-carcinogenic pulmonary edema. Diagnostic evaluation, therapeutic management, prognosis, and interprofessional care management can be seen on page 1150 in your books. Smoke inhalation injury. Many things we inhale are toxic to humans. Heat injury to the lungs usually affects the upper airway because of the reflex protection of the closure of the glottis in our throat. Chemical injuries involve gases that may be generated during combustion of materials such as clothing, furniture, or floor coverings. Chemical burns to the airways are similar to burns on the skin, except that they are painless because the tracheobronchial tree is relatively insensitive to pain. Systemic injury occurs from gases that are non-toxic to the airways. However, these gases cause injury and death by interfering with or inhibiting cellular respiration. Carbon monoxide is often the gas that causes this because of its colorless, odorless properties. A lot of people succumb to CO2 poisoning. Passive secondhand smoke. Children exposed to secondhand smoke have an increased number of respiratory illnesses with poor performance on pulmonary function tests. Maternal smoking is associated with increased risk of small infants and those who may end up with sudden infant death syndrome. In the long term, statistics show that children exposed to cigarette smoke as a child may develop chronic lung disease as an adult. See the family-centered care box on 1152. Long-term respiratory dysfunction. Asthma is still the leading cause of school absence in children. Asthma is a chronic inflammatory disorder of the airways characterized by recurring symptoms. airway obstruction, bronchial responsiveness, and an underlying inflammation process. This produces wheezing, breathlessness, chest tightness, and cough, especially at night or in the early morning. Box 40.13 has your asthma severity classifications. And box 40.15 has clinical manifestations of asthma. Take a look at those boxes. Therapeutic management. You need to read the peak flow meter guidelines on page 1155 and the prognosis page 1158 for statistics on asthma. Asthma can often be controlled, but it must be stressed to the parent and the child that they must take their medication and know the signs to look for that trigger an asthma attack. Drug therapy will be talked about shortly. Interprofessional care management, acute care, nursing care plan is on page 1159 to 1160. Remember that the child having an asthma attack will be anxious and uncomfortable. With long-term care, the focus is on outpatient management, so we must do a lot of teaching to the child and the parents. Long-term control medications, quick relief medications, you can read about these on page 1155 in your book. This is a metered dose inhaler using a spacer and a face mask. This works great for those children who just can't seem to coordinate that albuterol rescue inhaler without, that breathing and inhaling at the same time while you're pressing. Yeah, it's too much for some of them. So with this apparatus, you're pressing the medication into the tube, and with the seal of the mask around his face, all he has to do is breathe normally, and he breathes in all of the medication. So it's a great little apparatus. These are some more listed names of your different types of asthma treatment medications. This child with asthma is allowed to play as tolerated, but he's not going to go too far because he's on oxygen. Status asthmaticus is a medical emergency. Respiratory failure and death can happen if it's untreated. Continuation of respiratory distress despite vigorous therapeutic measures. Concurrent infection happens in a lot of cases. Therapeutic intervention, improving ventilation, pharmacologic agents, all of which will have to be administered probably in the PICU once they get them to the hospital. These are the child demonstrating two different types of aerosol treatments, one with a mask and one with the mouthpiece. Cystic fibrosis, multi-system involvement, increased viscosity of mucus gland secretions. Anywhere in your body that you have mucus production will be affected. Elevation of sweat electrolytes, increase in enzymatic constituents of the saliva, autonomic nervous system abnormalities. This is an autosomal recessive trait, defective gene inherited from both parents with an overall incidence of 1 in 4 having the disease. Increased viscosity of mucus gland secretions. Secretions result in mechanical obstruction. Thick, inspissated mucoprotein accumulates, dilates, precipitates, and coagulates to form concretions in glands and ducts. All of that being said means their mucus gets really hard and can block ducts in vital organs like the lungs, and we have to work really hard to keep it liquid and get it out. Respiratory tract and pancreas are predominantly affected. The sweat chloride test is how they determine if a child has cystic fibrosis. With the PKU test or the metabolic screening that's done at birth, that should also come back with a positive for CF, so that should give parents a heads up that they're going to have a child with cystic fibrosis. Diagnostic evaluation you see is the sweat chloride test, the universal newborn screening, and DNA identification of mutant genes if the parents have the foresight to have genetic consult beforehand. Presentation, CBOX 40.16 on page 1163. They will have wheezing respirations, dry non-productive cough, generalized obstructive emphysema, patchy atelectasis, cyanosis, clubbing of fingers and toes, repeated bronchitis, and pneumonia. Look up a picture of clubbing of fingers and toes if you've never seen that before. You might want to take a look at that. One of the earliest signs we talked about in OB was the meconium ileus in the newborn. That's usually one of the first indications that the child may have CF. Distal intestinal obstruction syndrome, excretion of undigested food in the stool makes their stools really bulky and foul smelling. There's a wasting of their tissues and sometimes a prolapse of the rectum due to passing such large, bulky stools. There's going to be a delay in puberty in girls, severe sterility sometimes in boys. The parents say the skin tastes salty. You don't go around licking your child, but when you kiss your child, you get that salty taste on your lips, and that is a briny taste, like pickle juice, briny, salty. There will be dehydration symptoms, hyponatremic, hypokalemic alkalosis, and hypoalbuminemia. Children with CF are living longer and managing their disease at an age of wanting to maybe get married and have children now. And those who had lung transplants can try after 1 year to have a baby. Those with the disease will have a more difficult time, if not impossible, but they can get pregnant sometimes and give birth to children. Even though the life expectancy of CF people is only 40, I guess she'd be around for a little while. Complications are present in almost all patients with CF, but the onset extent is variable. Stagnation of mucus and bacterial colonization result in destruction of the lung tissue. Tenacious secretions are difficult to expectorate. They obstruct the bronchi and the bronchioles. These are a list of some of the pathogens that cause infections in children with CF. The gradual progression follows chronic infection. Bronchial epithelium is destroyed. Infection spreads to the peribronchial tissues, weakening bronchial walls. This is why these children are candidates for lung transplants. No, I do not know if that will cure them, but it will certainly give them a fighting chance to live a lot longer. Chronic hypoxemia, pulmonary hypertension, which is a type of high blood pressure that affects arteries in the lungs and the heart. They may have cor pulmonale, an abnormal enlargement of the right side of the heart as a result of the disease of the lungs or the pulmonary blood vessels. They might have a spontaneous pneumothorax, which is a collapsed lung. And they may have hemoptysis, which is coughing up blood, or blood-stained mucus from bronchi, larynx, trachea, or lungs. They will put them through airway clearance therapies, bronchodilator medications, limit their physical exercise, but let them exercise to their extent, aggressive treatment of pulmonary infections, aerosolized antibodies, and home IV antibiotic therapy. Because these children are sick a lot, they may actually be able to be treated at home rather than going to the hospital, because the hospital is a dangerous place to go if you don't want to get sick. Management of GI problems. We have to replace the pancreatic enzymes from everything they're losing in all those frothy, bulky, foul-smelling stools. So with every bit of food they usually put into their mouth, they take a handful of pancreatic enzymes. They need to be on a high protein, high calorie diet, as much as 150% more than the recommended dietary allowance. We feed them high fats because they lose fats. So they can eat pretty much anything they want. Milkshakes, pizza. Relief of any intestinal obstructions like ileus and reduction of the rectal prolapse may require surgery. Treatment of chronic gastrointestinal reflux. Management of endocrine problems. Eventually pancreatic fibrosis occurs. Diabetes may result. Pancreatic enzyme deficiency, sweat gland dysfunction, and failure to thrive. Excuse me. Increased weight loss despite increased appetite. The median survival is 40 years. Progressive and incurable disease. Transplant increases life expectancy, but there's a problem with availability of organs, and then they have to deal with surgical complications. Interprofessional care management, hospital care, home care, family support, and transitioning to adulthood. Coping with emotional needs of the child and family, needs for treatment multiple times a day, frequent hospitalizations, home care, and implications of genetic transmission of the disease all have to be considered. So an important question here is, the most important consideration in managing TB in children would be, and I think I covered that in the notes, the answer is chemotherapy, because drug therapy for TB includes INH, rifampin, and pyrazimide daily for 2 months and 2 or 3 times a week for the remaining 4 months. The role of the individual drugs in first-line chemo of TB is unique. INH is responsible for the initial kill of about 95% of the organisms during the first 2 days of treatment. That's awesome. This concludes this chapter before I lose my voice. Thank you.